All three of us is going to speak at different aspects about how we connect with people living with MS, people we look after, and how that actually influences our practice and our thinking. And what I thought I would do is just sort of have a think about, you know, a big part of my work, which is also research really, and trying to sort of explain how do we come up with these ideas, where do these ideas for research actually come from, and how do we use our connections, our connecting, I guess, with people living with MS to sort of define some of these questions, and actually how can we do that better, because a lot of the times we kind of go a bit off track, I guess. So sorry, this thing's not sticking.
That's okay.
So can empathy and connecting improve research? And I guess, you know, I wouldn't be asking that if I wasn't going to say yes, but really, I guess the first thing is to just have a think. And you know, Jodie asking me to talk about this made me think about, you know, what is that really? And then part of it is kind of an intellectual exercise, I guess, where you sort of say, well, yeah, I get it. I can understand what you're telling me. I can understand why this is making you feel a certain way and get a sense of what you're experiencing. But then there is also a deeper level of connection, isn't there, where you kind of really can sort of share someone's feelings and really, you know, experience and really sort of live into, like walk in their shoes, as the theme of this is. And that's much harder, isn't it? Like, it's a much harder thing to do because we're all different. And I don't have MS, so I can only, you know, I guess I feel like my ability to experience those feelings and understand it improves over time because I've heard it so many times and I've gotten to know people that I look after for decades now. And, you know, you connect to people because you know them as well. So, but it's not always as easily said. So there's a lot of blockers to that, you know, connection in clinical practice and in the clinical setting, because there's a lot of information. You have a time window, so there's already, you know, you're a bit worried about that. You know, there's other people waiting. So there's a lot of blockers, you know, which makes you not as, you know, connected to someone that you're seeing right in front of you. And part of this is also your own mood, right? I might be in a bad mood that morning. You know, the kids may have driven me nuts. I could have been stuck in traffic, may not have slept well. And then you also come into something, you know, with some prejudices where you kind of go, oh, goodness, you know, I know this person is going to tell me they feel awful because they always tell me they feel awful. I don't feel like hearing it today. So there's a lot of your own sort of prejudices and feelings when you go into that situation, which might actually influence how you actually you know, are in that moment with that person. And there's a lot of thinking and sort of clearing your mind to say, well, okay, well, let's put that all behind us and let's start again and connect as best as we can. And then there's a lot of medical training to this as well. You know, we're actually trained as medical professionals to talk about things that we can fix. Like, we don't want to talk about the things that we can't fix. So if we can't actually fix the pain and the fatigue, maybe we don't want to talk about it that much. We want to spend a minute talking about it because, you know, not much we can do. And, you know, that's not always the right approach, or basic, you know, like having that sort of experience to talk about someone, about the things that are important to them is really important. So tapping into that connection can definitely improve, you know, that clinical session that you have with that person, but also their care overall, and how, you know, that therapeutic process of just talking to someone makes someone feel better, you know, even if it's not medication-based. But it also improves our thinking because it raises issues, things that we don't know, things that we can't fix. How do we fix it? We can't just always brush it under the carpet. So we do need to think, you know, it helps us to find solutions. So, you know, and that means really listening and also sometimes letting go of your specific point of view of what you want to achieve and getting that another point of view of that person that you're seeing in front of you. So there has been work done about this, you know, quite a bit for different medical specialties. And, you know, the question is always, you know, do people living with MS and their carers, their neurologists and their GPs agree on what is important? And the answer is it does to a large degree, but there's also quite a few differences. So in this study where they did a lot of structured interviews with healthcare providers and with people living with MS, they came up with a lot of different themes about what's important and what's not important for people with the disease, and then also the healthcare providers that look after them. And I think the main thing that the themes that you can see is that in the patient-reported goals, people really want to avoid side effects. They don't want any fatal side effects, which makes sense. They want to maintain and improve memory, prevent brain atrophy, which is quite an interesting one, because I think 10, 15 years ago that wouldn't have come up. So it shows also how educated our people and our clients are. People want a doctor who's aware, knowledgeable, and compassionate. So that's a really interesting one, because I wouldn't have thought about that as a big priority for people. Avoid losing the ability to walk, maintain cognition, stay healthy, avoid losing vision. And on the doctor side, you can see that it's quite similar. But it's very focused on preventing disability, effective medication, managing the symptoms, and quality of life comes a bit lower down, and building that relationship is perhaps is quite a bit lower down as well. But there's a lot of overlap, and this is also the thing, it's also using that language correctly and understanding where it actually is the same, because we're just using different words. So avoiding medicines and fatal side effects and risk minimization is important to both groups. And then just on the first one there, on the clinician side, on the doctor's side, you can see that we want to prevent disability. And yes, people living with MS want their disability prevented. Even if they, call it something specific, these can all be grouped together as well. So thinking about that, this is really quite interesting, because this is very much how we have focused some of our research programs, and how we adjusted depending on what's needed in the moment. So obviously, the coronavirus has been on everybody's mind, and we're all a bit sick of it. But it has been a really big focus of care and a really big focus of research that we suddenly had to adjust to, because that was the most pressing need of, the people that we were looking after, to know what the heck is going to happen. So, were people living with MS going to get terrible COVID? Were they all going to end up in hospital, in intensive care unit? What's going to happen to treatments? Some people at higher risk than others. And this required a lot of data collection. So we kind of immediately switched and started collecting data across Australia and New Zealand. And we are all connected, the neurologists looking after people with MS through a group. And we could set up a data collection sheet quite quickly to try and gather some information, because the only information we were getting initially was actually just through Twitter, to be honest. So it was all pretty scary, as you might remember. So this is just some of the results we've collected, and this is of course vastly underreported. I'm sure there's many cases that's never made it into this collection, but we have information about 104 cases now recorded across Australia. And most of these are from Melbourne. So, 83 in the blue there, with the second group, biggest group in Sydney, which I'm sure there's lots of patients that haven't been reported. And what we could see is that most people were actually on treatment, and most of them were on ocrelizumab, on fingolimod, and then a mixture of tysabri, cladribine, and tecfidera, and a few other things. And most people actually continued on their drugs throughout this. The reassuring thing is that there was 10 people who were hospitalised, so most people actually did really well out of this group. But it's still 10%, that was hospitalised. And what we could see is that, they all recovered in the end, and no one ended up in ICU. So that's been a really reassuring thing to see. And this has been obviously collected over a few years, with some vaccines being introduced into the mix as well recently. And what's reassuring is that when we look at the published literature, this is quite similar. So we know that, we're right on the mark, and most of the studies that's been published today from all over the world show that people living with MS that get COVID do mostly well. People who don't do so well are generally, those who are older, who have, really advanced levels of neurological impairment, and also people perhaps on ocrelizumab and Kesimpta. Those treatments might increase the risk, and also perhaps fingolimod. So it's basically really valuable to see that our experience is similar to the rest of the world. Looking at vaccination, so this was another big area where we just weren't sure how many vaccinations do people with MS need. Are they going to get relapses? Are people going to get relapses when they get vaccinated? Are they actually going to have a response? And there was a lot of concern because we could see that especially people on in these tablets here, like people on Gilenya and ocrelizumab, were actually not mounting enough of an immune response. So what was going to happen there? And very quickly, governments and policymakers had to adjust their approach to vaccination. So in Australia, we've also done a big study, and this is something that we at the Alfred have been leading with collaborators in Sydney to say, well, what happens in Australia? Because that's really the big question, because we didn't have much COVID initially. And this is sort of brand new information, but in the people that we've collected samples on, we can see that most people, so about 86%, sorry, what did I do there? Developed a response after their second dose of vaccination, so in people that we've collected that sample on. And in most people, that response was similar to someone without MS. So that's pretty good. But then again, as we expected, people on ocrelizumab, on Kesimpta, or people on fingolimod or siponimod, people had a slightly less of a response to the vaccines. And there were people also that had no response, and those people, again, were most likely to be on ocrelizumab. So again, just exactly what we would expect from biology as well. So this has really led to lots of adjustments and advice, and I think many people would know that we're up to the fifth booster now for some people, especially those on ocrelizumab and fingolimod. And the reason for that is really to try and keep those antibody and responses high while the infection is so rampant. So it's really important to keep up to date with those as well. Long-term safety, again, a big concern for a lot of people. And here again, this is something that we're very interested in. And we have had a look at cervical precancer, so something that affects women is particularly. Is it possible that we are increasing the risk of cervical precancer or cancer risk when we give people MS treatments over time? And firstly, we can say in general, in this study that we did, if you compare it to the general population, if we compare it to people with other immune diseases like lupus and rheumatoid arthritis, people and women with MS are actually not at a higher risk. But what happens if we actually look at people with MS, we know exactly what treatment they were given, how long they've been given it for, and we match it to what their MS is like and what treatments they've had over time. So in this study where we included about 151 people where we could actually match their cervical screening test or the old Pap test to their MS history, we actually found that women who have been exposed to high efficacy drugs, so these would be the fingolimod, cladribine, ocrelizumab, natalizumab, all of those type of drugs, Lemtrada as well, mitoxantrone, all of those drugs. A lot of these people who were in that group actually did have an increased risk of developing a precancerous lesion on their cervix. And what do we do with that information? This is something that's of concern to people living with MS, for concern for healthcare providers, and it's really sort of made us have a look at, how often should women with MS be screened for their cervical test? Is it every 5 years that they advise for the general population, or should it be every 3 years? And that's where we sort of really have put the mark. So it should be the same as it would be for other autoimmune diseases. So all of this, is sort of where we connect along research priorities and questions that's important to all of us, and we try and find those answers. And this is the second part of this study where we're doing a big linkage again, where we're going to collect people's immunisation records and also their screening records with their MS databases to see if we can, work out which drug it is. Is it all of them or just one? Or, how does it work? So that's where we're going further. So just thinking about this again, so we want to limit all of those, and then of course we want to limit disability, and particularly when we think about memory function, this is really tricky, because the thing is, it's not that easy to actually work out if someone's memory function is changing. And of course, we want to pick it up before someone has a major problem with their memory, right? So how do we do that? And this has been something that we've been focusing on a lot because it's common and it actually affects people's employment, their quality of life, their social function, and all of these things in a very subtle way. And it's really important for us to measure that. So as I show on this graph, what we want to do is not just say, okay, now someone is now cognitively impaired. We want to say, okay, hang on, you're still actually good. You're in a normal range, but you've lost a tiny, tiny bit, and we don't want you to lose a tiny, tiny bit. But how do we actually measure that? And how do we create better tests? So this is kind of what we've been working on as well. So, there's my leaves blowing away. So a few leaves off the tree of memory. So we've been working on this computerized test, MS Reactor, which I think many people would have done. It was offline for a while, but we're back online. And it's just a game, really, and it measures very, very simple tests like reaction speed, attention, working memory, in a very simple way, and people can just do this at home. And what we found with this is actually that, there is a group of people, and you can see on these complex graphs I'm showing you here, that there is a little group of people, about 20% of people who do this test who actually do get worse over time. So they just get a little bit slower if you take it over, this is 1,200 days. And if you're in that little group, it actually can show that you are at risk of getting worse from a physical point of view as well, which is really important because it's a different way to measure these type of memory changes rather than sitting through 4 hours of neuropsychological testing. Doing these simple tests at home is actually a good way to pick this up. And again, this answers a big, could potentially fill a big need that we all have, both from a clinical and from a person living with the disease point of view. And how else do we do it? So the other way we do it is we're really keen on apps. So we're going to be doing a lot of this. And there's an app called Floodlight MS that we are going to be using, and some people might be familiar with this already in the Floodlight Open version. And it gives you even more things. So it's not just about memory, but it can also measure subtle changes in your hand function, your walking speed, all of these things. And you can do it on your phone. It's pretty straightforward. This is a pinch the tomato test. It used to be a squash the bug one, but I think it was, there was an outcry about insect cruelty. So far no one is worried about killing the tomatoes. And it's really interesting because, doing that sort of simple test, you can get enormous amount of information. And people can do it as many times as they like. And it actually can show us, is their neurological function changing? Is their hand function changing? And very importantly, can we use this to actually broaden trials? Can we say, actually, we can use your hand function to see if you're going to respond to a drug. We can use your memory function to see if you can respond to a drug. You don't have to be able to walk 500 meters to be in a clinical trial. And this is where we want to head with this, to sort of improve the way that we do trials and include all of these things, so that people with MS can actually contribute to their own monitoring to say, yeah, I'm doing all of this at home, this is my information. How does that fit into the rest of the information you have with my MRIs and all the neurological exams you do all the time? Can we be more precise to say what's going to happen to me? What treatment should I be on? And that's, this is sort of the dashboard that we hope we can develop over time, where people can contribute this. So it's no doubt in my mind that, together and connecting better makes us stronger and makes us also smarter. And we can think about these problems in a much better way if we do this together. And you can see this in terms of research policy generally, where having someone with a lived experience to be, consulting on the trial that you want to do is becoming a very critical aspect of making that successful, and that makes absolute sense. I work with a fantastic team, and we're always trying to improve. So hopefully this was helpful, and you guys can give us more tips on how we can improve.